Okay, assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Abdul Mahsen. Thank you, Dr. Nafisa. Without any further ado, let me take you to this short but nice journey with our patient for today. He's a 44 years old male patient with no significant past medical history. He's a heavy smoker. Back in January 2016, he was diagnosed with stage 4 non-small cell lung cancer. It was a right upper lobe of the lung, adenocarcinoma, and with mediastinal lymph node, bilateral lung nodules, and right pelvic bone metastatic deposit, and right femur as well. The molecular profile showed an EGFR and ALK wild type with high PDL. Here you can see the PET-CT scan, which was done for the staging purposes at the time of this, and it's clear that the hypermetabolic right upper lobe lung lesion, no intra-abdominal metastatic deposit, and the mediastinal lymph node, and here the bone deposit as well. Okay, now as we have all details of the patient profile, we started the systemic therapy. Patient was started on carboplatin bimetrexid in our institution. Then he went to USA, where he received 4 cycles of carboplatin abraxane. He was on follow-up, of course, since then, and was doing well, tolerating his therapy well. But unfortunately, while presenting to cycle number 5, he complains of right clavicular pain. So the PET-CT was done at the time, and as you can see, it showed interval progression of the bony lesion, starting with the right clavicular lesion, as you can see here, and new left pulmonary lesion. And there was, as I mentioned, progression of all spine or most of the spine and bone lesion. So he was referred to our colleagues in the radiation oncology team, received radiation therapy to right clavicle and chest wall, 20 gray in 5 fractions. And now a new chapter was started in his journey as, of course, we switched his therapy to immunotherapy, nivolumab, 240 milligram every 2 weeks. So patient tolerated the therapy well, and that was, as I mentioned, in August or early in September 2016. Here you can see the PET-CT in October 2017, actually after more than 1 year of therapy. You can see that, okay, T11 lesion, there is some residual disease, but all previously seen intensely hypermetabolic lung and bony lesion are no longer seen. I have to mention here also that during that year, of course, patient was under follow-up. He went to USA once or twice, and all images were done at that time. And during that year, it showed also remarkable improvement, but here in this PET-CT was the best response we got till now. Okay. Other point I want you to see with me here, that the entire rectosigmoid colon there is hypermetabolic area, which representing some inflammatory change. At that time, the patient received 30 cycles of nivolumab. As we saw the PET-CT together, this raises the possibility of immunotherapy-induced colitis. And of course, after that, colonoscopy was done, biopsy taken, which showed moderately severe colitis and proctitis. So the decision was to hold the nivolumab at the time, and patient referred to our colleagues in the gastroenterology department, started an steroid therapy. He made a full recovery after a few weeks, of course, and with steroid therapy. And we resumed our treatments after that. He continued his therapy till October 2018. I can say at that time, almost we are about or finished almost the 2 years of nivolumab. By the end of his therapy, or by the end of the second year, he developed a second bout of also colitis pneumonitis. So started on steroid therapy, was under follow-up by pulmonology team and gastroenterology team. And fortunately, alhamdulillah, he made a full recovery after that. And as I mentioned before, he completed 2 years of nivolumab. Okay, so now another chapter started in our journey with this patient, which is the follow-up, or we can say the close monitoring of the patient, as he's not on any therapy right now. During, or I can say before we finished the nivolumab, the 2 years, we had a PET CT in April 2018, which was the first imaging study which showed no abnormal uptake at all. Only like sclerosis changes in the bone, which represent a treated disease. After that, as you can see here, in January 2019, the PET repeated again. Also, no hypermetabolic focus convincing for any recurrence or metastatic disease. But unfortunately, some of these images, due to technical problem, I was not able to bring with me. June 2020, also the same, no suspicious lesion. They were talking about subcentimetric right lower lobe pulmonary nodule with no interval changes in comparison with previous, but of course, no hypermetabolism. The case was discussed at that time in the tumor board and advised for surgery as for resection of that nodule, but the patient refused and opted to continue his follow-up. So the follow-up continued also. PET-CT in December 2020, almost the same. And here is the latest PET-CT, which was done in May 2021, evincing any hypermetabolic lesion, which suggests any recurrence or metastatic disease. Patient is doing well. He's asymptomatic, just following with us, as you see. He's, I think, due to the next follow-up this month or the next month, inshallah. So this, after we finished or we reached this will take us to some of unanswered questions that, okay, what about the long-term effect, of course, positive effect of the immunotherapy after stopping the immunotherapy? It can really cure cancer. How many cycles of immunotherapy are needed? Now, as we know, it's only up to 2 years. I'm not aware of any study that more than that. Is the PD-L1 is a marker of response for immunotherapy? And as I mentioned, we are not giving for more than 2 years. In the future, this can be changed. What about the late or delayed adverse event that can happen after stopping the chemotherapy? This patient developed colitis and pneumonitis. He recovered very well, but of course, this is a question. Can he develop anything in the future? So by this, I reached the end of my talk. Thank you.